Can you hear me too? No, it might be. So I think it's from the earphone. Screen share. Oh, actually, I can't hear you.
Are you saying anything? I couldn't hear you.
Now I can hear you. Yeah.
So I will start the recording and welcome you to the UAB Department of Pathology Grand Rounds. And today it's my great pleasure to introduce 4 different speakers, all trainees at various levels here at UAB in our department. And I'm always really impressed to hear the level of work that goes on, and I'm sure we will not be disappointed today either. So I'm to maximize their time, the format today is going to be similar to what we did when we did this last year. Each speaker is going to have about 15 minutes. I will briefly introduce each one at the before their talk, and then I will start a timer for 9 minutes and turn off my camera. And then after that 9 minutes, I will turn back on my camera, which will kind of give you that clue of about a minute to go to start wrapping up. And then we'll open it up to questions after that and then move on to the next speaker after that. So if there are no questions about the format, first off, we will hear from Abby Chapman, who's actually an undergraduate here working toward her BS with a focus on immunology. She already has several awards, including the Honors College Presidential Research Fellowship. And in addition to her work on placental growth with Dr. Thames Gilling, she has been working with Dr. Brandy McCluskey here in our department, and that's what she's going to tell us about today, which is a practice talk for something she will be giving later at the annual meeting entitled Cutting for Profit in the Pandemic. Abby, you may share your screen. Thank you.
Hi, everyone. Thank you for having me to present. I'm really excited, and I hope you are too. Let's see. Let's see if I can get this working. Okay. So I'm here to present to you Cutting for Profit in a Pandemic. And I had some help from awesome mentors from UAB and from the Arkansas State Crime Laboratory, Miss Cindy Moran and Dr. Daniel Dye and Dr. Brandy McCluskey. So after this, I hope that you'll understand the impact that the COVID-19 pandemic has had on our illicit drug supply, as well as the deaths associated with fentanyl-laced drugs. So I'm going to start with a little bit of history of drug use during economic hardships. So we'll start in the 1860s, which is during the Civil War. Morphine was often used by doctors who needed to amputate the limbs of those who had been injured. And soon morphine had begun to be prescribed for just about any malady. And this started a massive chain of morphine addictions. Then we'll move to the 1920s to the 30s, which would be during the Great Depression when alcohol was banned by prohibition. It was actually a popular source of comfort for those who were struggling economically during the Great Depression. Moving to the 1980s, this decade actually started with a recession, which I didn't know before I researched this, but crack cocaine became popular just because it was very affordable as opposed to other drugs at the time. And from 2019 to present, we have economic struggles as a result of the COVID-19 pandemic. Fentanyl cut heroin is a cheaper and easier alternative to pure heroin, and it's flooded the illicit drug market in the United States. So why fentanyl? Fentanyl is a synthetic opioid that's a popular cutting agent here in North America. So cutting is when you add a generally less expensive substance to a pure drug in order to increase the amount of the drug. So a drug dealer may have 5 grams of heroin and add in 2 grams of fentanyl and then sell that as 7 grams of heroin. I know a lot of the government agencies have used the slogan, illicit drugs don't come with an ingredients list, which I think is it speaks to the amount of things that are put in there that no one knows about. So according to the Drug Enforcement Administration and the National Institute on Drug Abuse, fentanyl can be 50 to 100 times more potent than morphine and up to 50 times more potent than heroin. So when you think about this, someone who maybe has never done drugs in their life and just chooses to try heroin that happens to have been cut with fentanyl, those people are going to have a lot less tolerance than someone who has done drugs for 20 years. So that makes it that much more dangerous for just about anybody. So the chemicals that are used to make fentanyl can be purchased fairly easily from online sources for low costs in wholesale quantities. So this makes the drug very profitable for those who manufacture and deal it, since they can upcharge for it. So this is the data from the Jefferson County Coroner and Medical Examiner's Office. So in 2019, there was a 40.6% of drug toxicity deaths that were related to fentanyl, and that jumped to 64.6% in 2020. And then it jumped again, not as much, but 68% is still a significant amount in the first quarter of 2021. And then in the second quarter, it jumped again to 81.3%. So from 2019 to 2020, there was a 25.6% rise in overall drug-related deaths and a 100% increase in fentanyl-related deaths. As a side note, I do want to make it kind of clear on this. So the percentage for the increase in fentanyl-related deaths, that's going to be raw data that was put into the percent change equation. So it doesn't have to do with the amount of overall drug-related deaths. So it's not, that percentage isn't used in that equation. I just wanted to kind of make that clear. So from 2020, for 2020, the first and second quarter versus the first and second quarter of 2021, there was a 36.2% rise in overall drug-related deaths and a 64.7% increase in fentanyl-related deaths. So we also used data from the Arkansas State Crime Laboratory, and they saw that in 2019, there was 34.7% of those drug-related deaths were involving fentanyl. And again, as we saw in the Jefferson County data, there was a massive jump in 2020, which would be the main time whenever COVID really hit, here at least. So there was a 53.2% of those drug-related deaths that had fentanyl detected. We saw another rise in the first quarter of 2021 with 60.2%, and it decreased a little bit in the second quarter of 2021 with 56.6%. However, again, that is still a significant number. So if we compare 2019 to 2020, there was a 22.8% rise in overall drug-related deaths and an 88.1% increase in those with fentanyl detected. Then if we compare the first and second quarter of 2020 to the first and second quarter of 2021, there's a 41.1% rise in overall drug-related deaths and 48.4% increase in those with fentanyl detected. All this happened with COVID. The dramatic and disproportionate increases in fentanyl-related deaths are likely due to the ease of obtaining fentanyl from the internet, as well as the continuation of utilizing trafficking channels between Mexico and the United States, despite the fact that there have been COVID-19 restrictions and border closures. So throughout the pandemic, we've seen heroin prices increase and the availability of fentanyl decrease. But purchasing heroin that has been cut with fentanyl will decrease the price of the overall drug as well as increase the potency of that drug. So based on observations of the data from both JCCMEO and the Arkansas State Crime Laboratory, cocaine and methamphetamine have also been being mixed with fentanyl quite commonly during the pandemic. So it's not just heroin that this is an issue with, it's also other illicit substances such as cocaine and methamphetamines. So in conclusion, according to our latest information from JCCMEO, 2021 actually ended with 76.6% of drug-related deaths being related to fentanyl toxicity. And it's projected for 2022 to have an even larger number of deaths. And we expect to see this continue to rise as the pandemic and the epidemic continue. The issue of fentanyl-related drug deaths has been exacerbated by the COVID-19 pandemic due to economic stressors such as not being able to go to work, due to being ill, and the supply chain breaks from Mexico to America. So the drug dealers are having to get a little bit more creative as to where they can get this kind of substance from. And this makes mixed drugs the most cost-efficient route for both the drug dealer and the drug purchaser. This deadly combination will continue to wreak havoc on the medico-legal death investigation system. So here I have some references. They're all interesting to me. They may not be to everyone, but they are to me. So I would highly recommend checking them out. And here's the contact information. I'm Abby, the presenter. And then Miss Cindy Moran, she probably has the most information on the data from Arkansas, just because that's kind of her domain. And then Dr. McCluskey and Dr. Dye, they both helped with the information from JCC, NEO, and UAB. So thank y'all for listening. I hope you enjoyed it.
That was outstanding. You already have a question in the chat. It looks like it's been answered though. But that was very sobering statistics. I mean, it's very scary to see how those things go along with each other. Are there any other questions? I mean, we worry and hear so much about COVID, but the way it changes behavior, it's really striking, and you capture it very clearly in your statistics.
Absolutely. I just actually recently finished watching a Netflix documentary, which, I mean, I've checked their sources. They seem pretty okay. But they said that a lot of reasons for people becoming addicted to heroin is because of the opioid crisis that we had with the OxyContin. People would go and purchase or attempt to purchase it from their doctor, who then wouldn't give them the prescription because they didn't need it anymore. And so they would turn to there being an illicit drug dealer, and those pills fetch a pretty high price, and so they can't afford it. And they say, well, why don't you just try heroin instead? It's cheaper. And they do, and then all they want is heroin.
So scary. Well, great, and good luck. Is it later this month, your presentation? Is that correct?
Yes, sir, that's right.
Well, great job. So if there are no other questions for Abby, we will move on, and I will get ready to reset my timer. So next up, we are going to hear from Dr. Chae-Myeong. She is an American Heart Association funded postdoctoral fellow in my laboratory. Before coming to UAB in November of 2017, she received her doctoral degree, her PhD, from Kyungpook National University in Daegu, South Korea. She already has over 20 publications to her name, 8 of which are associated with my lab or other collaborators here at UAB. Although her primary focus is research on the kinase family PDKs, she has also taken on lead roles in another project in the laboratory on O-GlcNAc, and today she's going to tell us about cardiac hypertrophy transitions in response to prolonged protein O-GlcNAcylation. Dr. Hatz, the floor is yours.
Thank you. And thank you for giving me an opportunity to share my research here today. Today, I'm going to talk about chronic effect of a protein O-GlcNAcylation in heart. It has been reported that the heart disease is #1 cause of death in US and worldwide, even in the COVID crisis. And diabetes increases a risk of heart disease and mortality 2 to 4 times more. On the other hand, the cardiovascular disease is the leading cause of death for diabetes patients. A link between diabetes and heart failure is suggested. High blood glucose level induces protein O-GlcNAcylation, which is a post-translational modification mechanism that modifies proteins to adding UDP glycanate group. O-GlcNAcylation is a dynamic cellular activity added by its transferase OGT and removed by O-GlcNAcase OGA. The protein O-GlcNAcylation has various target distribution, including transcription and structural proteins and metabolic proteins. Our lab also previously found that hyperglycemia induces protein O-GlcNAcylation in type 1 and type 2 diabetes mouse heart. And our collaborative work with Dr. Lalita Shividesamantu lab showed type 2 diabetes increases protein O-GlcNAcylation in breast tumor, and it is reduced by metformin, which is an anti-diabetic reagent. Also, there is several evidences that diabetes patient with heart failure has higher protein O-GlcNAcylation level, and it is correlated with its duration and blood glucose concentrations, and negatively correlated with its cardiac functions. At the same time, another evidence is revealed that pressure overload heart hypertrophy is also related with protein hyper-O-GlcNAcylation, and excessive protein O-GlcNAcylation causes heart failure and cardiac sudden death. However, protein O-GlcNAcylation in heart is a double-edged sword, and it's not always working as pathological mechanisms. In the ischemic reperfusion injury, protein O-GlcNAcylation is necessary to protect cardiac damage and promote to cell survival. With these evidences, we hypothesized that protein O-GlcNAcylation contributes to cardiac remodeling, which may progress to pathophysiological effects when sustained in cardiomyocytes and leading to heart failure. We generated cardiac-specific inducible dominant negative OGA mouse model, which is compete with endogenous OGA and ultimately inhibits OGA function and induces protein O-GlcNAcylation. This dominant negative model was first found from OGA splice variant, which is naturally occurred diabetic blood. We designed 2 weeks induction for short-term protein O-GlcNAcylation induction and 24 weeks for the long-term effect. And we validate its cardiac specificity over expressions. First, we confirmed that DNOGA expression induces protein O-GlcNAcylation, and longer expression induces more robust modification. And this induction level is similar to physiological induction level, such as diabetes-induced protein O-GlcNAcylation. After 2-week and 24-week induction, we found that mice had a cardiac hypertrophy at 24 weeks, both left and right ventricles. And female mouse also had robust hypertrophy. However, the cardiac systolic function was maintained. We only found the cardiac remodeling, which is matched with hypertrophy agent. To find specific mechanisms, we conducted transcriptome analysis using mRNA sequencing tools. We found that the protein O-GlcNAcylation distinctively changes transcriptomes, and O-GlcNAcylation duration is also a strong effect of differential mRNA expression level. Next, we did biased target analysis to find cardiac hypertrophy markers. AMP and BNP showed gradual increase by the duration, and SERCA2A and alpha-MHC started to hypertrophic signaling from 2 weeks. And cardiac fibrosis signaling were induced at the long-term inductions. To find an insight of mRNA sequencing analysis, we did unbiased pathway analysis using differentially regulated factors. At 2 weeks, ribosomal translation pathways and inflammatory responses was increased, but started to decrease of cardiac muscle functions and metabolic mechanisms. Also at 24 weeks, we found strong cardiac remodeling fibrosis pathways were increased, and cardiac fatty acid metabolism was reduced. Johns Hopkins group reported on O-GlcNAcylation analysis, which showed about 100 mitochondrial proteins can be O-GlcNAcylated, but the detailed function is not revealed yet. This group suggested 12-hour induction of protein O-GlcNAcylation induces mitochondrial respiration rate. So we also analyzed mitochondrial oxyphos complex activity using Seahorse XF analyzer in frozen heart tissue. This technique is developed our lab neighbor, Gloria and Dr. Dolly Osama, and we found that mitochondrial complex 1 and 2 activities were significantly decreased only in long-term protein O-GlcNAc inductions. And we also found that not only oxphos complex activity, another mitochondrial representative enzyme, citrate synthase, activity also decreased compared to cytoplasmic enzyme lactate dehydrogenase. To find whether it's mitochondrial number reductions or activity reductions, we analyzed mitochondrial DNA copy numbers and it weren't changing. So we expect that long-term protein O-GlcNAcylation may cause decreased mitochondrial activity. Although mitochondrial DNA number was not changed, we also found that long-term protein O-GlcNAcylation reduces part of oxphos complex subunit protein expressions. Next, we analyzed upper level of the oxphos complex. We found that TCA cycle enzyme expression also reduced in long-term induction of protein O-GlcNAcylation. To find another upper level of energy metabolism pathway changes in our mouse model, we checked the glycolysis pathways. The transcriptomic analysis showed that several glycolysis steps were downregulated in DNOGA mouse. Next, we further examined the hexose biosynthesis pathway, which is a UDP-GlcNAc synthesis mechanisms, and we found that the critic HBP pathway is not changed. Cardiac muscle is omnivore of glucose and fatty acid, so we check additional fatty acid oxidation pathways, and we found that protein O-GlcNAcylation in heart is not only reduces glucose metabolism pathways, but also reduces fatty acid oxidation mechanisms. Next, we thought that the glucose and fatty acid metabolism are suppressed in O-GlcNAc mouse. The oxidative stress level may also affected to the O-GlcNAc mouse, and Dr. Raj in our department helped for further investigations of NRF2 ARA pathways. We found that NRF2 and its downstream mechanism NQ01 are downregulated in chronic DNOGA overexpression mouse. In summary, protein O-GlcNAcylation induces cardiac hypertrophy and its remodeling. And protein O-GlcNAcylation changes cellular transcriptomes by its durations. Sustained protein O-GlcNAcylation reduces mitochondrial enzyme activity, but does not change its mitochondrial DNA copy numbers. And long-term protein O-GlcNAc suppresses glucose and fatty acid metabolism pathway transcriptomes. And chronic protein O-GlcNAc levels reduces NRF2 ARA signaling. And thank you for your attention, and I appreciate for my support, for the support from my mentor, Dr. Adam Wendy, and Dr. John Chedam, and all of my lab members and our pathology department collaborators.
Great job, Jenna. The talk is now open for questions. It looks like we already have 2 in the chat. Would those people like to unmute, or I can start reading?
Yeah, that was very nice presentation, Jenna. Congratulations on that. It's nicely progressing. So I'm just curious, in one of your Western blots where you compared the acute versus long-term impact of O-GlcNAcylation, and looks like most of the proteins which you see modified are upper range, like more than 50 kilodalton, I believe. Do you have any thoughts on why you don't see anything in the lower molecular weight stuff? And just
that is another my curiosity to why it's always more happens on the 50 molecular weight 50 and upper range side. I think there's some enzyme, mitochondrial enzymes like PDK and or some PBH that are sized at 50, around 50s, and it might be affected by that things, not only specific the target. We don't know the target yet. We don't have any ideas, but some proteins that metabolic rich is size in the 50s and over. That is on my crude think. But
one thing I will add to that, and this is mostly spearheaded by John Chatham, is the transfer conditions do make a difference. And this is something that we're troubleshooting with his laboratory and a few others. And hopefully he'll be sending out some guidelines for people interested in this soon. There was another comment. Prachi, did you want to make your comment? Talking about the complex activity versus the enzyme levels. And you actually did show that, if you wanted to go back to that. The work with Gloria.
So using seahorse analysis, we made a mitochondrial isolations and then keeping a different substrate to measuring each of the oxphos complexes. And we found that complex 1 and complex 2 was reduced, but complex 3 and 4 has a tendency, but couldn't get a statistical significant reduction.
Okay. Well, thank you for the comments and questions. And if there are no more, we will continue on. And I thank the first two speakers to sticking to time and even being a few minutes ahead. So we are good to go. So our third speaker is Nikki Panzica, who is a medical student specializing on the study of medical record data from the Jefferson County Coroner Medical Examiner Office death certificate data. Prior to joining us here at UAB, she received her BS from Auburn, and she has extensive leadership and service experience already at this early stage in her career. And later this month, we'll also be presenting at the American Academy of Forensic Sciences annual conference, where she will be telling them about suicide and mental health observations from a coroner medical examiner office. Nikki, the floor is yours.
Well, thank you so much. And thank you everyone for the opportunity to be here. It's greatly appreciated. All right, let's get started. So this project is on suicide and mental health, observations from a coroner medical examiner's office. And Dr. McCleskey did help me a lot with this one, so thank you to her. So overall, the medical community considers the diagnosis of mental illness as a condition that carries very high risk of suicide ideation, attempt, and completion. But the vital health statistics are often derived from death certificates that rarely include any sort of mental health diagnosis. So researchers would benefit from getting data from the primary source, like the coroner or medical examiner's office that investigates the majority of these deaths. But the current medical legal death investigation system doesn't really allow for this to occur. So standardization of death certification practices overall would improve the quality of mortality data. And this is definitely true in cases of suicide when we're assessing the impact of mental illness, and that would benefit clinicians, patients, and families. So quick background of the death certificate. So on the death certificate, suicide is a manner of death. That's captured as a structured field as only one of 5 options. Part 1 of the death certificate centers on causes of death, and those are the events that directly resulted in the death. While part 2 is used to collect information on the contributing factors. So it's very uncommon for mental health diagnoses to be listed on part 2 of the death certificate. And one study even saw that only 5% of death certificates had any information in part 2 at all. So there's a lack of information on the contributing factors to any deaths. So the objectives of this project was to use a primary data source, the JCCMEO, to investigate the individuals who died of suicidal means and present observational details regarding the prevalence of mental illness, so PTSD, depression, bipolar disorder, and others in these deaths. So after attending this presentation, I hope all of you have a better understanding of the purpose of death certificates and the lack of their contribution to the vital health statistics for mental health. So I use the database at JCCMEO here in Birmingham to look for decedents with the manner of death of suicide between January 2013 and May of 2021. So the demographic information, the circumstances surrounding death, and the reported history of mental illness were collected from the case information from this database. Information from the scene as well, including witness accounts and interviews with friends and family at the time of death, were obtained from narratives. Sorry, my cat just jumped on the screen. So information from the scene was obtained from narratives written by medical legal death investigators. So to be clear, this is reported mental illness. This is what the family and friends reported as their decedent, their friend, family member having these mental illnesses. They're not diagnoses from UAB. So the results and the time frame we looked at, there were a total of 757 deaths certified from manner of death as suicide. So the majority of these were by gun use. Following that was asphyxia, which includes carbon monoxide poisoning, drowning, hanging, and fire use. And following that is drug use and injuries such as falls and motor vehicle accidents. 82% of these decedents were white male, the overwhelming majority. Behind that, we had 15% white female, 15% Black male, 3% Black female, and then for the other demographics, it was close to 0. So in total, 50% of the decedents had a reported history of some sort of mental illness. Again, these are reported histories, not diagnoses, but 42% was reported to have depression. And below that, we have 5.8% with bipolar, and then PTSD, schizophrenia, and then a general mention of mental illness by their friends and family were at around 2% each. So in the future of this project, we have been looking at witness and family reports of mental illness and comparing that to the medical records at UAB. So we're trying to see how these reported mental illnesses compare to people who actually went and got to see a psychiatrist, who had the opportunity to see a doctor, to be diagnosed, or to receive treatment. Additionally, we're looking to create some sort of strategy for future coroners and medical examiners to consider listing a mental health diagnosis in part 2 of the death certificate. So like we said at the beginning, this part of the death certificate is usually quite empty, even in cases that weren't suicide. And it would be very beneficial to get a more accurate look of the correlation between mental illness and suicide if we could get that on the death certificate. And this information will help better inform our clinical colleagues of the association of mental illness and suicide when treating their patients, which would benefit all of us. So these are my references, and thank you so much for listening.
Thank you, Nikki, for yet another great talk. We're open to questions now. So I definitely think you're both very well prepared for the meeting later this month and will represent UAB very, very well. So thank you.
I have a question.
Yes, go.
Yeah. So why, I like the presentation. Thank you. Do you know why that part of the death certificate often doesn't have that information in it?
So from my understanding, it's a difficult thing to do, which does make sense to me that friends and family or loved ones of the decedent seeing that like depression or whatever it may be on the death certificate might be difficult for people to see that and think, oh, are you implying that I could have done something differently, that I could have helped my loved one more to prevent this from happening? And that's what I've heard in talking with Dr. McCleskey and discussing this topic with people. It would be a very big change and a difficult thing to do for sure.
And one other aspect of that I'll add a little bit, what you say is correct, is that family members get really upset. They have to show death certificates to banks and such as proof of death. And it really upsets them to have information that they consider private family matter on the death certificate. HIPAA has only made that worse. So now they think that we're breaking the law if we include medical information on a death certificate that they don't want anyone to know.
Adding to that, would you guys speculate that it actually has the opposite effect, though, by stigmatizing it and not getting the discussion out there so that people aren't getting treated? I mean, is that the main goal of this type of work?
And that's that's the question I'm trying to ask with Dr. McCluskey, is as a society, I feel like we've progressed forwards a lot in recognizing that mental illness is very common, and there are solutions, there are things we can do to help people, and it doesn't need to be something hidden or to be afraid of. And I think a lot of society has reached that point in that understanding, and it's our job as physicians, you know, to help push that. So that's part of why we're doing this.
And Adam, I'll add, there's a little bit of what you say is correct. I think there's a little bit of the not in my backyard mentality, though. That's fine for all other families, and I agree with it completely. But when it's my family, then suddenly I want it all hidden in secret and no one knows.
Yeah, it's definitely obviously hard for any family to go through. And the hope is that physicians and having the right statistics out there could, you know, prevent this from happening all the time, and help destigmatize it.
Thank you. Very nice presentation. Thank you for your answer.
Thank you.
I have a question. Great job, Nikki. And is there any way that something could be done in the future where that part of the death certificate does not have to become public when the families take it to banks and stuff? And we could make that into more of a medical side versus the certificate itself?
That's a great question. I think that would be a good way to do this. And I think in general, death certificates are something that even as future doctors, my medical student classmates are never really trained on what goes on a death certificate or how to do that and how to fill it out. So I think we could all use in our career field more education on the matter. And that would help to possibly do things like that, make that part of it more private. I agree, though. That is a great idea.
Actually, I have some experience with that, Marissa,
yeah.
If you don't mind if I add. First off, you're right, Nikki. You need education in how to do this. But concerning your suggestion, Marissa, that would be very similar to birth certificates, which have extensive lists of information concerning the mother's health, which are private and not made publicly available. The death certificates have never been that way in the past, and the people I've talked with at the CDC are a little loath to change because it's never been that way. However, the electronic death certificate, since they're mostly completed online now, is making it possible. Some states have different laws, and they have begun to do exactly what you suggest. So the CDC is looking at that to see if this somehow adversely affects or helps their data. And then if they find that it helps, I suspect that they will start pushing for what you suggest to be true. I and some other forensic pathologists have wanted that for years.
That's one. That would seem to be the solve both issues. We would have more complete information, but not have to tell people that truly don't need to know.
Right.
Yeah, right. Brandy, you're going to say something?
I figured Dr. Davis would answer. I had something, we talk about this a lot, of course, but part of the value of this project and working with our colleagues in psychiatry to try to help drive this data forward is that most people have no idea about the gap in mortality data statistics and how that relates to research dollars and people paying attention to health conditions. You've heard us mention it many times. We had a COPD speaker come and talk about COPD a couple years ago before COVID. And, you know, he's like, oh, it's the third or fourth leading cause of death. It's not possible that that's good data. But most people don't learn. Thankfully, the medical students here that sign up for our course get to learn about how to do a death certificate. We give an autopsy lecture. Dr. Benson's given it. Dr. Atherton's given it. I've given it. That talks about how to figure out a death certificate. I don't know if Dr. Anderson's on here, but there was some talk at some point in time about death certification making it to a USMLE exam. I don't think that's probably ever going to happen, but if it did, then medical students would learn about it. And so at this point, if you're a medical student here and you have interest, you might learn about it, but otherwise, most physicians go out into the world and don't really understand what that certificate means to public health data.
Right.
Renae, I saw you turn on your camera. Did you have a comment?
No, but I was always interested in the relationship between, or if there's a possible relationship between pathology and psychiatry. So this has been super informative and great.
Thank you. Thank you for that comment. Okay, if there are no other questions or comments for Nikki, thank you very much. And we will move on to our final speaker of today. So to finish off this round of trainee speakers, we will next hear from Dr. Bassel Zein-Sabatto. I hope I pronounced that correctly. He is a postdoctoral research fellow who, prior to coming to UAB, received his medical degree from Damascus University in Syria, where he also completed an initial residency. Since being here, he's completed a residency and has now moved on to his research interests. He already has 3 publications and will actually be presenting 2 abstracts next month at the USCAP 111th annual meeting, one which he will not tell us about his work with Majid Galuzi, and today he will tell us about his work with Chirag Patel in a talk entitled Evaluation of the Gray Zone in Staging Between T3 and T4A Colonic Adenosarcomas. So, and I think you should be able to share your screen now. And the floor is yours.
Thank you so much, and thank you for inviting me to present today. So my name is Bassel Zein-Sabatto. I am a postdoctoral research fellow, and with a primary focus on research on GU and GI pathology. And today I will be talking about a study, a project that is an ongoing project. I'm working on this with Dr. Patel and in collaboration with other co-authors and faculty members, and it's about the evaluation of the gray zone in staging between T3 and T4A colonic adenocarcinomas. So I have no disclosures to make. So as a little of a background, first, as you may know, in staging of colon cancers, tumors that invade beyond the muscularis propria into the pericolonic soft tissue are staged as T3 tumors, while T4A tumors are those that extend all the way to involve the visceral peritoneum, which is basically the serosal surface lining the outer surface of the colon and surrounding soft tissue. So, and it's not always an easy task on the pathologist to decide whether a tumor is a T3 or a T4, especially in borderline cases, where we have these cases in the gray zone, where the tumor is really close to the serosa, but not actually at the serosa, especially when you have a surrounding fibroinflammatory reaction that can distort the image and can theoretically disrupt the integrity of the serosa. And this adds to the confusion and the difficulty of staging between T3 and T4 in many cases. And here I quote the latest edition of the AJCC Cancer Staging Manual, where they state the significance of tumors that are within 1 millimeter from the serosal surface and accompanied by serosal reaction is unclear, with some but not all studies indicating a higher risk for peritoneal relapse. So we have some sort of controversial results in the literature about these tumors. And our aim in this study is to investigate specifically these tumors that are close to the serosal surface with bridging fibrotic and or inflammatory reaction, and their association with overall survival as a first step in our study. And later on, we can assess more parameters. So we searched the archives of the pathology department for all colorectal cancer cases during an 11-year period between 2003 and 2013. And we collected a total of 232 actually colorectal cancer resections that were originally staged as a T3 or a T4. And we excluded all the tumors that were staged as a T4B, meaning those tumors that involved other adjacent organs. So those were excluded. Also, we excluded all the tumors that involved non-peritonealized surfaces, because here we are trying to focus on the relationship between tumor and peritoneum. So for example, rectal tumors that arise below the level of the peritoneal reflection those were excluded. And two pathologists actually reviewed the slides for all the cases, and we tried to assess the relationship between the invasive front of the tumor and the serosus surface based on two main parameters. First, we measured the distance under the microscope, whether the tumor is present at the serosus surface, or if it's within 1 millimeter from the surface or more than 1 millimeter in distance. Also, the second parameter that we looked at is basically the presence of fibrotic and or inflammatory reaction that is contiguous all the way between the tumor and the serosus surface. So based on these criteria, we were able to classify our cases into different categories. And on the equivocal cases, we tried to obtain consensus. So we showed the cases for 3 other pathologists that are specialized in GI pathology. So I have these figures here to demonstrate the categories that we classified our cases into. We have a total of 200 cases. So I'll start with the category 1. It actually includes those tumors that invade all the way and involve the serosal surface, the peritoneal, the peritoneum, which these by definition and according to the AJCC guidelines are considered unequivocal T4A. For tumors in categories 2 and 3, here we have the tumor getting really close to the serosal surface within 1 millimeter in distance, measured accurately under the microscope. And we have an associated fibroinflammatory reaction that is bridging all the way in category 2. And category 3, we don't have any inflammation associated. Now for categories 4 and 5, on the other hand, the tumor is much further from the serosal surface, more than 1 millimeter in distance in both, but we have a bridging fibroinflammatory reaction in category 4, and we don't have any reaction in category 5. So on category 5, I want to point out category 5 basically represents tumors that are unequivocally considered PT3. Any pathologist will agree that these are T3 tumors. So we have these on one side of the spectrum, and we have category 1 on the other side of the spectrum, which are considered unequivocal T4A. So these two groups basically will serve as our control groups to compare, and the other groups in between sort of in the gray zone. And of special focus will be category 2 tumors, the most controversial tumors, because these tumors get really close to the serosal surface and they have this surrounding associated fibroinflammatory reaction that can disrupt the serosa. And these are specifically the tumors that were mentioned in the AJCC, and they have conflicting results in the literature. And actually these tumors represented around more than 30% of our cases. So these are not uncommonly encountered in practice. And interestingly enough, these tumors were staged originally by the pathologist, and the pathology report were staged as T3 in 85% of the cases, while they were staged as T4A in 15% of the cases. And this really highlights the inconsistent staging and the confusion around these controversial tumors among pathologists. Here on the left side, I have an example just to show one example of these tumors. We have the tumor glands invading deep into the pericolonic tissue, and they incite this surrounding reaction, the fibrosis or the vascular congestion and the dense inflammatory infiltrate that you can appreciate here, that is continuous all the way to the serosal surface here in black, inked in black. So for survival analysis, for now, this is still work in progress. For now, we only have data on the overall analysis. We excluded the cases of category 3 because of the low number. We also excluded all patients with a follow-up time less than 3 months. And we tried to assess overall survival. We had a total of 175 cases for the purposes of survival analysis. And on the Kaplan-Meier log rank test, you see here in the plot that the tumors in the controversial category 2 here in the yellow line appear to correspond, the curve appear to correspond to the tumors in the category 1 in the blue line, especially later in the disease course. when compared to C5 and C4. So in univariate analysis, when we are analyzing the hazards and comparing the groups against category 5 as the reference, you can note here the hazards and the hazards plot that category 2 and 1 sort of have a similar risk or hazard when compared to category 3, which is the unequivocal T3. Also worth mentioning that category 4 tumors had a consistent protective effect when compared to category 1 and 5. So to conclude, these controversial tumors, colorectal cancer tumors that are within 1 millimeter from the serosa with associated bridging fibroinflammatory reaction, are actually frequently encountered in practice, and they remain inconsistently staged among pathologists. In terms of overall survival, for the time being, our findings only suggest that these tumors would behave more like a T4A rather than a T3. And also category 4 tumors tend to behave or appear to behave more like a T3. So of course, further investigation is needed. We need a larger cohort, and we are in the process of collecting more cases to increase our sample size, and we have to correlate with the disease-specific survival and the rates of disease recurrence, in hope to get a better understanding of this controversial group of tumors and lead to more reproducibility of colorectal cancer staging among pathologists. And that's what I have. Thank you all for listening, and I can take any questions.
Thank you so much. Definitely kept the steam going with excellent talks there. The presentation is now open for question. I see you already have one in the chat. Dr. Harada, do you want to unmute and ask it?
Sure. Well, it may not be statistically significant, but then C4 tumor looked like has a better survival than C5. I was just wondering, maybe they're having inflammatory or reaction might be protective. That's kind of interesting. That any reason?
Yes, actually that's really interesting to me also, because we suppose that inflammation and reaction would add a worse prognosis, so to speak. But right. Apparently in C4 here, it appears to have a protective effect, maybe because there's more fibrosis. So the type of fibroinflammatory reaction, we have to go more in detail into that, because if you have more fibrosis, that's probably more protective. But when it's very close to the serosa, this might, disrupt the serosa itself. And right. That's probably what's the inciting factor for a worse prognosis. So maybe the distance actually is much more important than the presence of inflammation.
I see. And I also
have a quick question. I'm sorry.
Sorry, I was just going to say, are they treated differently or similarly to everyone?
So yes, so right now we are collecting, because this is just initial data, we are collecting all the clinical data regarding the treatment of these patients and the the N stage, the M stage. We try to stratify all these and try to account for all the possible confounding factors to get a better, clear image. This is just obviously just just gives a better insight for now.
I have a quick question on the on your study. One of the images you showed, there was a discontinuity of the ink on the surface. If you see that, I'm talking about C1 versus C2. Did you get a recut to make sure it is not an artifact?
Yes, actually, that's a great question. And this is actually this idea exactly that what we have in mind as a future project that we can build on this. So first, what we did not get any recuts at this point, but later on, we can definitely do recuts and see if this tumor actually invades all the way to the serosa or it retracts back. And we will collect and see the percentages of if making recuts can change, the pathologist interpretation, because we are staging the stage, the stage here. So yeah, totally.
Thank you. That's a good, yeah.
Okay. We have 2 additional questions in the chat. Dr. Alexander, did you want to unmute or do you want me to read it? Okay. He asked, was the cause of death by tumor or with tumor?
So this was only overall survival. So we will later on we will collect data to assess for disease specific survival. So this is just overall survival. And that's probably, we did not reach statistical significance yet, and hopefully we get more meaningful data in the future.
Okay. And the last question in the chat is, are there any differences in terms of tumor type?
Tumor type regarding...
So, Bassel, it's me. So
yes,
in terms of morphology, is there anything like in terms of subtype of tumors or histologic features, and also like the pattern of invasion, like pushing border versus infiltrative or single cells? Because I believe similar things may have been done in other organs, and sometimes is the front of the tumors that where it's invading that maybe has different characteristic features. I don't know if you guys have looked at that.
Yes, so in colon cancer, they assess the tumor budding and they assess the invasive front of the tumor. And we are collecting for now the grade of the tumor, if it's moderately or moderately or poorly differentiated, and if that will affect the stage. And also we're collecting the data on the type of tumor, as you mentioned, because for example, mucinous tumor tend to grow around, so they can go into the peritoneum. So we are also collecting data on these, and we still don't have the statistics on those, but we definitely have this in mind. And yeah, thank you for this question. Yeah, definitely.
And just to add to that, yeah, there is tumor budding. It's not required for a lot of these colon cancers, but
yeah,
what we plan on doing is once we can scan these and start using algorithms to assess these tumor buddings. At that point, it should be more reproducible with a computer.
I was just thinking, because for example, now this is of course not related to your project, but in the upper urinary tract, tumors that have a lot of these pushing borders, when we did a study, they tend to be associated more with Lynch syndrome. So I wonder if there's anything similar that, has a different impact on the interface between tumor and stroma that may be related to more than just the morphology.
Yes, yeah, absolutely.
Yeah, and we did collect the data on how much MSI testing was done on these, and most of them did not have them back then. But and usually MSI high tumors in the not usually, but some MSI high tumors in the colorectal area, they have a similar morphology, very medullary type. But we can do that in the future.
Thank you.
Adam, you're muted if you're speaking.
Oh, I'm muted. Thank you. I was asking, I saw Dr. Alexander unmute. I was wondering if he had anything to add. I was the one that was still muted as well. Okay.
With all this data, Adam, it seems like it'd be fairly easy to figure out if the tumor actually killed the person. And that's why I raised that question.
Yes, we are right now collecting all the disease-specific data to get survival data that is disease-specific and to correlate all these categories with recurrence. Absolutely.
Yeah, Bassel did a lot of job. And, he did a huge job collecting all this data. So we just need to get it analyzed for statistics.
Great.
Thank you very much.
Thank you.
Perfect. With that, I want to thank all 4 speakers for the outstanding presentations and for staying on time. That is something that doesn't always happen, and I really appreciate that, both the quality and the diversity of projects. It's really great to showcase all the different areas of expertise in the department. So thank you for that. So everybody, please join me in thanking the speakers, and I hope to see you all next week when we hear from 4 more. Thank you very much.